I'm starting a topic with lacrimal apparatus. Structures of the lacrimal apparatus. These are the structures: lacrimal glands and the accessory lacrimal glands, puncta, canaliculi, lacrimal sac, and nasolacrimal duct. So the picture shows lacrimal glands. This is situated in the lacrimal fossa, the frontal bone, the upper side. Do you know what is the function of the lacrimal gland? Anybody? Function of the lacrimal gland. Nobody knows? I am repeating. What is the function of lacrimal gland? Because the picture shows lacrimal glands is that some ducts are opening in the superior and the superior fornix and inferior fornix. Something comes out. What is that? That is the aqueous. Aqueous is secreted by lacrimal gland. There are two other glands that is called accessory lacrimal glands. Do you know the names of these glands? Because many times I have told you. What are the names of accessory lacrimal glands? One is the glands of Crouzet, situated in the superior fornix and the conjunctiva neck. And the other is the glands of Wolfram, just above the usual glands. They also secrete the aqueous. Then what is the difference between the aqueous secretion of the lacrimal glands and the accessory lacrimal glands? Basic secretion, because the Wolframs and the Crouzet, it goes on secreting the aqueous continuously. That is called basic secretion. And another is reflex secretion. That is by the lacrimal gland. Suppose if you touch the cornea or the conjunctiva, there is a reflex, irritation of that. So afferent pathway that goes through the system nerve and so many nerves, and that goes into lacrimal glands and secretomotor, and that causes the secretion of the aqueous. That is the reflex. You can measure both these things. If you put the Jalocaine drop, and then you see all the secretion and this one tears thermaltech, we are this bloating paper we are keeping inside. That is the basic secretion. If you touch, you irritate the nasal mucosa, and that is the reflex secretion. So one is the reflex secretion, another is the basic secretion. Wolframs and the Crouzet goes on secreting, and that is the reflex mechanism. Suppose irritation, conjunctivitis, uveitis, scleritis, that causes the more lacrimation of that. You see that. Before that, we should know what is the embryology of the lacrimal glands and the lacrimal apparatus. These things. Anybody know? Lacrimal glands embryology. It arises from which layer? You know, whenever I start that, I also take part in the beginning, embryology. There are three layers, forebrain, between, and that. What are these layers? Ectoderm, then mesoderm, and endoderm, or neuroectoderm. It should remain, it should be known. This ectodermal origin. Can you tell me the one name which is originated from the ectoderm, surface ectoderm, embryology of this? Ectodermal, surface ectodermal origin. Complete. It is lens. Lens is originated from the surface ectoderm. Cornea also, but surface epithelium and the Bowman's membrane that originates. Another the stroma, descemet membrane and the endothelium that is from the mesenchyme. So we should know this. So the lacrimal glands, the other all Wolfram's and glands, the cilia, the Meesmann glands, they are originated from the surface ectoderm. Whatever the connective tissue or the blood vessels under that is mesoderm or musculature layer. The neoectoderm, nervous layer or other part. So that also embryology. What about the surface, the epithelium of the lacrimal apparatus, puncta, and canaliculi, lacrimal sac, nasolacrimal duct? This epithelium of these things, that is also ectodermal in origin. So remember, all of the lacrimal apparatus is originated from the surface ectoderm. Epithelium part and sac and the lacrimal apparatus, lacrimal glands, Wolfram's and the process of the that we should know that, because in the beginning we should know that. After that, the anatomy of the apparatus part. Taking the lacrimal gland situated here, having the two parts, and the pre-septal part and the orbital part, and this that is the part. Nerve supply and the secretion part. That is. Then comes the puncta. Puncta is the elevation is there, the nasal side. Puncta, this is just the fenestration and the hole is there, and then it is in the canaliculi. First the vertical canaliculi and then the horizontal and common canaliculi. It opens in the lacrimal sac. And sac is in continuation with the nasolacrimal duct. And the duct opens where? Inferior meatus. So whatever the tears are secreted from the lacrimal glands or the probes and the Wolfram duct, they are coming in the upper fornix and the lower fornix, in the puncta, canaliculi, sac and nasolacrimal duct, and then comes in the nose. And from the nose it comes to the mouth. That is the drainage of this aqueous secretion. If there is some pathology, some irritation part or some obstruction, then it hampers. Then there is a drainage difficulty. That we are going to see. One is the hyperlacrimation, another is the epiphora. Hyperlacrimation is somewhere irritation is there, the more secretion is there. Then epiphora, when this drainage, punctum, canaliculi, sac, this is obstructed. Somewhere it is obstructed. The tears flow over the cheeks. That is the epiphora. Different causes we are knowing. Today we are discussing that, some part of it. What are these? That is the lacrimal sac and the nasolacrimal duct anatomy. You should know that. There are certain bones, nasal bones, and lacrimal bones. They come in between. If you take the section in front, the skin part and the muscle, then comes the lacrimal fossa and the nasal bone, and then the nasolacrimal duct will open the meatus and that. So anatomy, at least you should know that. So embryology, anatomy, that is also a must. Then comes the tear films. Whatever the tears are secreted, that is the aqueous. If you see in detail the histological section of this, that is the structure of the tear films. It's a very thin layer, but divided into three parts. Mucous layer, innermost, aqueous is the middle one, and lipid is the oil layer. You know from where these are secreted from this. Let's say the mucous layer, from where it comes. This is the 0.1 mu. The mucous, innermost layer. It comes from where? Secreted from which layer? There are mucous glands within the inside. Mucin, that is secreted from. This is the innermost layer. It protects the layer. It gives nutrition to that. Middle one is the 0.6 to 0.7 mu micromillimeter. This is secreted by lacrimal gland and Wolfram's and the closest that part. Accessory lacrimal gland. This is the third part. Second part, third part is the liquid layer, oily layer. Do you know from where it comes? One is coming from the mucus layer, the conjunctiva, another is the lacrimal gland, and then the superficial part which prevents the evaporation of the aqueous. That is from the lumen gland. You know, lumen glands are inside the carpal plate, both sides, upper and lower part. That causes oily part. These layers are different features. Mucus layer, it protects the cornea. Aqueous layer, it lubricates and it also lubricates. Oily layer, it prevents the evaporation part. If there is some deficiency in either of the layers, that causes the dryness of the eye. So these all layers are very important. Suppose there is a fibrosis of the conjunctiva, mucil layer deficiency, then mucil layer or mucil, that layer will be deficient, causing the dryness. If the aqueous is deficient, there will be again more evaporation. Oily layer is not there, then more evaporation. So these causes we discuss in this diagram. That is the structure and physical sections of this tear film. Then there is certain functions of the tear film. Keep the cornea and conjunctiva moist so that there is lubrication, there is no dryness. Provide oxygen to the cornea. It gives oxygen. Washes away the debris and the noxious irritants. Protective layer of it. It prevents infection due to the antibacterial activity, the substances. So it is antibacterial also. Facilitate the movement of the lid over the flow. Because the oil in all these layers, whatever the movement of the lid, clothing, opening, that gives facilitation of the movement. So that these layers they will lubricate the cornea and other parts. If the cornea is not lubricating and not wet, it's going to be dry. Conjunctiva dry, this cornea dry, that is it. If any layer is deficient, that function is also important. Then, suppose we know that what is tears with secretion is going inside and mucous membrane in the mouth. But we should know the mechanism, how it goes inside, how it is drained there, how if the blinking is helpful or not. We should know that. Secretion of the tears are continuously secreted throughout the day by essentially of basal secretion and the male reflex secretion of the lacrimal gland, as I discussed earlier. Then there is an elimination of the tear. Suppose from the lacrimal gland, the tear comes to the superior fornix and the lower fornix. It comes from the puncta to the canalicular sac, and then will be dust. But how it goes? Is there any mechanism, any function of it? That's a diagram clear-cutly indicates that when the eyelids closes, suppose whenever eye closes or you close the eyelid, what happens? During the blink, contraction of the orbicular muscle, because this is the orbicular muscle, orbital part, the preceptor part, there is one more part, ulnar muscle, that is attached to the sac also. Whenever blink, these muscles, they pull out the sac. So sac is dilated. That is the mechanism of it. Orbicular fibers of the ulnar muscle inserted on the lacrimal sac causes distension of the sac, creating negative pressure, which siphons the tear to the sac. When eyelid opens, the ulnar muscle relaxes, the sac collapses, the positive pressure is created, which forces the tear down the nasolacrimal duct into the nose. See the first diagram A. It's a normal. Tear is there, blue is the tear. Just see the B part. When the eyelid closes, once the eyelid is closes, orbicular muscle contracts. Ulnar muscle is also the part of the orbicular oculi. It attached to the sac. Once closing, it drags out or distended the sac part of the lacrimal sac. Whenever there is a distance, a vacuum is created. You can see that the blue part whenever there is a closing and the extension of this one. So tears, what is the aqueous in the lower cornix and this is puncta. The distension of this create a negative pressure. This punctum and the canaliculi and sac, this is filled up with the tears, the negative pressure. This is during the blink. Whenever we open, whatever relax ulnar muscle, it relaxes, gives the goes at the position, primary position, it presses the sac so that a positive pressure creates, it propels down the aqueous in the lower part. That is the mechanism of the tear secretion. Closing and opening, that causes. The closing is siphon-like action, it fills up the tear, and opening it with the pressure and it goes. You might be thinking that closing it causes prolapsing of this. The reverse. Closing is the siphon action because the muscles is attached to the lacrimal sac. It fills up there and opening it with pressure, it propels down the tear. That is the mechanism of the tear drain. Remember this thing, we can ask you how the tears are drained in the lacrimal sac and the nose part. That is how this mechanism acts. Then comes the dry eye. Because so many times you are saying the cornea is dry, the conjunctiva is dry, dryness of the part. Nowadays this is very common disease, dryness. Definition: dry eye disease is a multifactorial disease of the tear film. This is a disease of the tear film, an ocular surface that results in symptoms of the discomfort, visual disturbances, and the tear film instability with the potential damage to the ocular surface. There is combined action. Deficiency of the tear causes the visual deficiency and this is a dryness of the ocular surface disease. This is a combined mechanism, group of disorders. That is the definition. If we ask you the definition, you have to write this. The dry eye disease is a multifactorial disease of the tear film of the ocular surface that results in symptoms of the discomfort, visual disturbances, and the tear film instability with potential damage to the ocular surface. Deficient, and it gives differential, this blurring of the vision of that, and ocular surface damage, conjunctivitis, redness, watering, irritation, all that, or many times easily discharge. That is the multifactorial disease that is called the dry eye. Classification, there are so many factors. Classification, broadly we are dividing into two: aqueous deficiency and more evaporative. Aqueous deficiency means mucin and the other part, the aqueous or the oily layer. If there is something deficient, that is called the more evaporation or the deficiency part of this. One part, you see that these are the factors. Aqueous deficiency. Aqueous deficiency means whenever the aqueous is deficient, no secretion, that is not reaching to the lower cornix and the punctum to the level. Causes of this one: Sjogren's syndrome and the non-Sjogren's syndrome. Sjogren's primary and secondary and non-Sjogren's with a certain feature. Primary part. Primary part means Sjogren's. Suppose there is a disease of the lacrimal gland and the disease of salivary gland. Some atrophy, some infection, some alacrimia, there is no secretion, there is less deficient, suppose any tumor or like that, that is the Sjogren's part. And xerostomia also. This is the primary Sjogren's disease. Secondary immunodeficiency or immunological disorder, that is rheumatoid arthritis or like that also is non-viscosity, deficient secretion of it. Because the rheumatoid arthritis is a collision disease, that was a fibrosis of the conjunctiva, the less deficient, the lacrimal sac and like or lacrimal gland, so that less deficient, less secretion of it. So primary Sjogren's disease, primary and secondary, primary lacrimal gland, secondary the collision disease associated with it. This is one factor. This is an aqueous deficiency. Because if we ask them, what right, describe all factors causing the dry eye, and you have to mention this, divided into two, the deficient and more evaporative part. So deficient, non-geographic lacrimal deficiency. Some disease of the lacrimal glands like that. Lacrimal glands obstruction. What are the glands? They are secreting that. There is the obstruction, the fibrosis of this one. Reflex block. Suppose there is a corneal disease or any operation has been done, so there is no reflex mechanism go to the lacrimal gland. That's for the deficiency of this aqueous secretion. Systemic drugs, so many drugs, anti-histaminic drug, anti-emetic drug, so many drugs they are causing less deficiency. So this is the less deficiency, less aqueous secretion of the deficient secretion, Sjogren's, the non-Sjogren's, and the primary, secondary, lacrimal deficiency, and all these things they causing the less. Ultimately, is the aqueous is the deficient part. Once the aqueous is deficient, so many mechanisms occur and causing the dry eye. Second part is the evaporative part. Suppose the aqueous is the normal, but more evaporation is there. Oily layer is not there. Slightly, immediately there will be evaporation there, causing the deficiency in the oily part, aqueous and the mucus, causing the dry eye. In detail, meibomian glands deficiency. Suppose the meibomian glands are deficient, causing less fatty oil, secretion in the superficial layer. That is one cause. Disorder of the lid aperture. Suppose eye remains closed, proptosis or like that, there more evaporation, more exposed to this, no blinking at all, no blinking rate. Same thing. Drugs action, there is an isotretinoin, it causes the more evaporation of this. So these are the intrinsic means inside factors. Extrinsic factors, vitamin A deficiency, topical drugs preservative, contact lens wearer, ocular surface disease, light allergy. Thus we'll see in detail that vitamin A deficiency. Can anybody tell why this vitamin A deficiency causes the dryness? Why the vitamin A deficiency causes the dryness? Because vitamin A epithelial growth that is responsible for this. Whenever there is a deficiency, just give it cirrhosis and fibrosis conjunctiva. Whenever there is a fibrosis conjunctiva, there will be no less mucin secretion, causing the less mucin secretion level, causing the dryness. That is one of the cause vitamin A deficiency. That is why we are advising vitamin A in dry eyes. Topical drugs, preservatives, like that. So many preservatives, they cause this deficiency of the dry eye. Benzalkonium chloride, that is the toxic part of the conjunctiva and the cornea. It causes some inflammation of part, causing the dry eye. That also extrinsic part. Contact lens wearer, so the contact lens that causes the papillary hypertrophy. Same thing with dry eye. Ocular surface disease, allergy, like string catarrh, vernal keratoconjunctivitis, all the fibrosis and follicles and the papillae, they are less secretion of the fibrosis and the less secretion of the low mucin, causing the dry eye. So these are some factors causing that aqueous deficiency. These are the causes, Sjogren's and non-Sjogren's, and the more evaporative part, intrinsic factor, the extrinsic part. We can ask you in the Viva, what are the intrinsic factors causing the dry eye? What are the extrinsic factors of the? You should know these things. These are certain factors causing. There are so many others are also factors that causing the dry eye, but these are common parts. Suppose I give you one example. Suppose one person is sitting in front of the cooler. More air is blowing and cold air is blowing. What it will cause? Will it cause the dry eye? Just think of it. And why? I say it will cause the dry eye. Why? Suppose there is their eye is glowing part that is just more dryness of the system and that causes the dry eyes. More evaporation of the system. That is pressure, more evaporation. That is. Suppose I am sitting in front of the laptop, like this is all front of the laptop and the computer. That causes the dry eyes. Why? Why it causes? I mentioned this factor. Third is the low blink rate. Is it related to that? All the time, suppose I am computer like that, 2-3 hours, my blinking rate is lower down. More evaporation. What is the dry eye? So blinking, frequent blinking is also must. So this computer, the laptop or the mobile phone, incline that also causes this one. So the wind, blowing wind, more computer, blinking rate, disease of the lid aperture because there is no lubrication. They also all causes intensity activity factor. They causes the dry eye. Remember these. Some clinical features: irritation, foreign body sensation, feeling of the dryness, irritation and the dry part of the all the time, ocular discomfort, it many times is the blinking, this is blurring of the vision also, ocular surface, conjunctiva, the cornea becomes just like conjunctiva. That is the last. Include presence of the stringy mucus and the particular matter in the clear film, lustreless ocular surface, conjunctival gyrosis, reduced or absent marginal tear strips, and the corneal changes in the form of the punctate epithelial erosion phenomena. These are some features and signs. How will you diagnose? Suppose there is a dry eye. There is a certain diagnosis. Tear film breakup time. What is the breakup time? Once the tear film is formed, we will see that breakup time. How we will test this one? Normal is 15 to 35 seconds. 2 drops of the fluorescent dye, that is instilled to the lower cornea. Blink once. Sit in front of the slit lamp. Make a slit. You will see a green line in front of that. Continuously see that. Whenever there is a dark spot, the black spot comes in between that line, that is the point. That is the tear breakup time. If any layer is deficient, no lubrication, that will be lower down. Immediately that will come out. The normal is 15 to 35. Less than 10 or 5 is the dye eye. Thermal test, same a blotting paper and we floating that, and wetting pause is all refractor layer, and that is 15 seconds for we are keeping that. That also shows if it is less than 5, that measurement keratoconjunctiva is fixed. Rose Bengal test. A rose Bengal is very irritating. There is a ABC factor in there. C part is the only the punctate keratitis in the conjunctiva. B is the more in the pituitary part, and A is the more corneal involvement of that, the severe part of this. It means the conjunctiva and the cornea, that causes the degeneration of that part of this one, so that we can stain them to the Rose Bengal test. So A, B, C is the grading. So A is the highest degree, B is in between, and the lower is that. Just to see that color of the conjunctiva and the cornea, we can see that how the cornea and the conjunctiva is stained part. That is a Rose Bengal test. And the other test also, tear level of the lysozyme and the lactopharyngis, tear osmolarity and the conjunctival impression cytology. Impression cytology and tear osmolarity. Tear osmolarity, whatever the tears, we can know the concentration of the 265 or more than 300. And less than that is the dry eye disease. So these are some tests we can do: tear breakup time, thermal test, Rose Bengal test, and other lysosomal activity lactopharyngis, so that we can diagnose. Once we diagnose, how we diagnose? Tear breakup time, thermal test or rose Bengal test. Then we are treating them. How to treat them? Tear substitutes. I can hardly see so many tear substitutes are there. Artificial tear like methyl cellulose 0.25 to hypermalose, polyvinyl alcohol, so many hyaluronic and this one all chloroquine activities. So many tear substitutes are there. So frequently like mild, moderate and severe part, we are starting just immediately. Frequent drop 4 times, 5 times, 6 times or many times, severe dry eye 1 hourly also. And the bedtime also that we that gel part so that it remains for a longer period. So the tear substitutes are the important part for the treatment. Topical cyclosporine. Cyclosporine is the anti-metabolite drug. 0.5%, 0.1% is helped by reducing the cell-mediated inflammation. Cell activity that it reduces the cell activity so that less inflammation. It also helps. Mucolytic 5% acetyl 15 helps by dispersing the mucus threads and decreasing the tear viscosity. That also mucolytic we are having. Topical retinoids useful in the reversing the cellular changes squamous metaplasia occurring in the conjunctiva of the dry eye patient. So these are the few drugs, important drugs, tear substitute, topical cyclosporine, mucolytic, and topical retinoid. We are starting immediately then. And for the day and for the night, the gel part. Because the gel is the concentration is more, so that it will remain for a longer period up to morning part. The eye will not remain dry. When we start that frequent drops and the dry eyes, that we will start. There are certain other measures also. Preservation of the tear. How we preserve? We are starting that part, but suppose there is a deficiency of the tears at a drainage part. By reducing the evaporation and decreasing the drainage, whatever the tears are secreted, they are drained away. Even in a dry eye, somehow if we can stop or we can inhibit the drainage part of the tear, so it will not go, it will remain in the eye for a longer period. So there will be no dry eye. How? Evaporation. By reducing the evaporation and decreasing the drainage. Evaporation can be reduced by decreasing the room temperature. Because the heat that causes the more evaporation in dry eye, that we can decrease that if temperature is reduced. Use of moist temperature chamber and the protective glasses. We can use the glasses also, protective chamber, and the temperature can be reduced. These are some artificial or temporary methods. Or punctal occlusion. Because the puncta, the drainage is through the puncta, if we occlude that, if we prevent the drainage through the puncta, that problem will be solved, that the deficiency is there. To decrease the drainage can be carried out by collagen implants. Some there are silicone implants if we are introduced into the puncta. So there will be no drainage. So tear will remain for the body for a longer period. Or cyanoacrylate, this is a glue part that adhesion there. So that will be also problem. Cautery, laser, if you obstruct that punctum, that will also happen. Laser occlusion, by the laser if you occlude that. And the surgical occlusion, suppose you put the suture there in the punctum. That's an option. These are some methods where we can prevent the evaporation of the drainage part of the surface. So first we have treated the dry eye, the and the cornea. Somehow the mucolytic drugs or the artificial tears or the mucolytic, this cyclosporine or longer or the short acting, and then prevent the drainage part and the evaporation also. That is the treatment of this. It is complete initial dry eye. So we have seen today all the structures of the lacrimal apparatus. Open. Then there are certain diseases. What is the dry eye? Certain factors, including the primary and secondary part. evaporation, mass evaporation of the deficiency form. How we treat that surgically or mechanically or drug. That's how we can treat this. If the question comes to prescribe the drugs to the dry eye, what are the factors, how will you define the dry, how will you treat that, it includes every part of every structure of this. That finishes today's lecture, the primary lecture. In the second part, I'll discuss the all lacrimal diseases, lacrimal, hyperlacrimation, epiphora, dacryocystitis, chronic and acute, and congenital dacryocystitis, and there are certain measures of the DCR, the conventional, or the nasal lacrimal. This is endo-nasal. That in second term. So this is the first part of the diary. Let's finish it.